10 minutes. So after this, now this vasoconstriction prevents blood loss. Now later what happens? The body will go into a state of vasodilatation at the site of injury. The vasodilatation occurs of small blood vessels as well as vicinity large blood vessels also. So what is happening? So this first stage is called hemostatic phase. Now comes the vasodilatation, where immediately after the vasodilatation, vasoactive components are released. So how they are released? So you know how the first how a clot mechanism, how a clot forms. Are you aware of it? There is a cascading mechanism of coagulation. So immediately at the site of injury, there is a coagulation. What are the cells that are involved in coagulation, students?
Clotting factors and
Platelets, isn't it? The platelets go and plug the hole. Wherever there is injury, they try to go and plug the hole. So they form a thrombus. So once the thrombus is formed, a fibrin is formed. It seals. This seals the injured site and prevents any further blood loss. Then platelets also secrete some enzymes. These are called, they produce adenosine diphosphate. Adenosine diphosphate, and then they also produce platelet-derived growth factor and transforming growth factor beta. So these two are released by the platelets that come and plug the hole of injury. So once these are released, what happens is these act to attract the inflammatory cells, that is the neutrophils and the macrophages are attracted by the platelet derived growth factor that is secreted by the platelets plugging the wound area. So what are these things doing? So once these the polymorphonucleoside, that is the neutrophils and the monocytes, macrophages, when they come, they produce vasoactive amines. So these vasoactive amines, histamine, serotonin, are produced. So once the histamine, serotonins are produced, this produce vasodilatation. They increase the vasopermeability. So first, vasoconstriction, platelet plugging. Platelets are releasing adenosine diphosphate, and simultaneously platelet-derived growth factors and transforming growth factors are released. This attract the inflammatory cells into the wound. Once the inflammatory cells come into the wound, they release vasoactive amines, that is histamine, bradykinin, kallikrein are secreted. So these vasodilatation, increased vascular permeability. By this increased vascular permeability, more and more inflammatory cells leave the blood vessel into the tissues, and they carry on some functions. So what are the functions that these inflammatory cells carry at the wound? Immediately, within minutes after an injury, is they trigger phagocytosis. They trigger a so what is this? Why the phagocytosis is necessary? Because they will they phagocytize any dead tissue there due to trauma. They also phagocytize any bacteria that have entered the wound. So this is very much necessary. And they also check the fibroblastic activity. Now the second response is the fibroblastic activity. So now I'll just show you the picture. See here, this one is the first is the hemostatic phase, then inflammatory phase. The third phase is the proliferative phase. The fourth phase is the remodeling phase. Normally, they exclude the hemostatic phase. They say 3 phases for wound healing: inflammatory, proliferative, and remodeling. See, in inflammatory, because of the action of platelets, all the macrophages, neutrophils have come into the picture, and then they phagocytize, and they release vasoactive amines. But neutrophils are not as such necessary for the process of wound healing. So now let us see how the steps are occurring. Okay, so here once the healing in the proliferative phases, this starts from third day to 3 weeks. From third day of the first 2 days are the inflammatory phase. Second phase is the proliferative phase, which starts from the third day to third week. Now, from the in the inflammatory phase, there will be all signs of inflammation in the wound. What are the signs of inflammation? These are described by Celsius. Then these are tumor, scalar, dolor, rubor. All these are seen in the wound. This is because of the inflammatory mechanism that is growing on. So next starts the proliferative phase. So in proliferative mechanism, what is started? The fibroblasts are formed from the macrophages. Now these produce the collagen and the ground substance. The ground substance is nothing but the glycosaminoglycans and proteoglycans. And also epithelialization starts. So during the proliferative phase, epithelialization occurs. Next is the ground substance or the matrix is synthesized. So this is nothing but granulation tissue. This is called granulation tissue. So what is this? The fibroblasts secrete newer blood vessels, newer collagen. So this newer blood vessel synthesis is called angiogenesis. So angiogenesis is occurring, producing the granulation tissue. So students, what is granulation tissue? It is nothing but budding capillaries and the fibroblasts in the wound. So what we see as pink tissue is the young fibroblasts and the budding capillaries with the matrix, the ground substance there. This is called granulation tissue. So angiogenesis and the budding capillaries and the lining epithelial cells. So this is the granulation tissue that forms. Let us just see how little more what is happening in the micro. Sometimes these may be asked in your events in the wound healing for migration of the epithelial cells shortly after injury. During the inflammatory phase, the basal epithelial cells in the lining epithelium, it may be skin, it may be mucous membrane, the near the basement membrane, these cells migrate and they multiply and they start migrating across the defect. So how they are, the framework for these epithelial cells to migrate is formed by fibrin. This is a support structure. This fibrin is formed by the platelets. So now there are also integrins that are secreted. So these integrins help in the epithelial migration along the wound. So these act as sensors and integrators between the extracellular matrix and the epithelial cell cytoskeleton. The extracellular matrix is nothing but the young the collagen that is being formed by the fibroblasts, and then the epithelial cells form the lining. So integrins, they act as they integrate these two structures in the wound. And then between the epithelial cells, there are tight junctions. These tight junctions now will prevent any fluid coming out of the tissues. You know, in the early inflammatory phase, there is increased vasopermeability because of the secretion of the vasokines, the histamine, bradykinin. Vasodilatation is there by the action of the macrophages that have come into the wound. But now once the epithelialization starts, tight junctions prevent any more leakage from the wound. Now the basement membrane, that is the basal cells, they form the structural support and attachment of the epidermis to the dermis. So basement membrane is which integrates the dermis and epidermis. And now how do we get the tensile strength in the wound? So in early phase, that is within 2 weeks, it is only within few days. It is the collagen has not yet started. So within few days, it is because of the granulation tissue, that is the result of blood vessel and the angiogenesis, epithelialization, and also protein aggregation. This is responsible for the early tensile strength of the wound. Now, how does the wound proliferation come to end? This process cannot go on and on and on. So what is that is, this is by contact inhibition. That is, when two or more similar cells come into surface contact, contact inhibition occurs and there is no more reepithelialization. This is very, very essential because this checks growth of excessive tissue in the wound. If excessive tissue is secreted, that results in hypertrophied scar, keloid scar, sometimes even malignant transformation can occur. In chronic ulcers where the healing process is delayed for a long time, this the cells, the reepithelialization, the epithelioid cells that are reforming, there is a chance that malignancy can occur. Example, long-standing ulcers like venous ulcers, squamous cell carcinoma can form. Chronic burn wounds or osteomyelitis, or in chronic scars where there is continuous regeneration process, this contact inhibition is lost, there is a risk of malignant transformation. So this in chronic wounds only these occurs. So we know that during proliferation there is epithelialization and formation of ground matrix. In the early phase it is called granulation tissue, and the tensile strength in the early phase is because of the blood vessel growth, epithelialization, and protein aggregation. In the late phases, it is because of the collagen. But in the early phase of the wound, that is within a week or two, it is because of this. So, I think you have understood what is contact inhibition and what is the importance of contact inhibition. So, this is the process that is occurring at a microscopic level during the proliferative phase. So the cells that are secreting these bradykinin and all are the macrophages, and these the fibroblasts are derived from the matrix that is being formed by the macrophages. Now, the tensile strength of the wound is only 10% at the end of first week. In a month, it reaches to gradually increases, and by 70 to 80% of the wound strength is reached by third month to 60 month. But remember, never it will reach to normal tissue. The tensile strength of the wound is compared to the normal tissue in and around. So in early phase, it is only 10%. By 6 months, around 80% is reached, but never it will match the tensile strength of normal tissue. Now we have seen the remodeling phase. In the till now we have seen the inflammatory phase and the proliferative phase. Now what is happening in the remodeling phase? So this remodeling phase will grow as much as from 3 weeks to 2 years. So there is continuous remodeling of the scar that is occurring. So here in remodeling, what is happening is there is maturation of collagen, contraction of collagen tissue, and also there is transformation of the collagen that is laid down. In the initial phases, in the proliferative phase, it is the collagen 3 is deposited, while in remodeling phase, this is converted to collagen type 1. So collagen type 3 is converted to collagen type 1 and this remodeling keeps on occurring until this ratio of collagen 1 to collagen 3 is 4:1. That is, here collagen 1 is replaced, the collagen 3 is replaced by type 1. So here this should be in the ratio of 4:1. So now what I mean to say is here in this graph, you can see these are continuously occurring. It is not that inflammation followed by proliferation, followed by, there is some overlapping always. So during inflammatory only proliferation will start and overlap, and proliferation is overlapped by remodeling. So this is a continuous process that is occurring. Now during this, so at the end of the remodeling, what is the how is the scar that is formed, the tissue that is formed? One thing you have to remember is, suppose there is a skin loss, you may get a scar, but in this scar, the the sweat glands, hair follicles, sebaceous glands are not there. They do not regenerate. So this is what you have to um, this is what you have to remember. They do not have appendages, and very superficial wounds may have little scar formation, but deep wounds will have a lot of scar that is formed. So now then we have in healthy in fetal cutaneous wound, it is found that there is no scar formation at all. So in early intrauterine um, period, when there is any injury, or sometimes they are doing intrauterine surgery to the fetus, in that case there will not be any scar formation. It will heal normally. There is no there is no inflammation, or there is no practically no fibrosis, because this is a growing phase, and that will be replaced by normal tissues. Now what are chronic wounds by definition? See, we have seen that wounds that do not heal within 3 months are considered as chronic wounds. There are so many causes why the wounds do not heal. We'll consider them. So these factors will make the wound chronic, and they may refuse to heal. So now we know that there are 3 phases of wound healing. One is inflammatory phase, the second one is proliferative phase, third one is the remodeling phase. So what are the factors that inhibit wound healing? Look, we can divide them as local factors and systemic factors. So in local factors, some conditions that prevent this proliferation or migrations of regeneration are not allowed, or not secreted there. One thing is infection or ischemia, when the proper blood supply is not there to the wound. Suppose a leg ulcer is there, where the ischemic limb is there, the blood vessels are obliterated, the wounds will not heal, because the blood is the one which carries all the macrophages, platelets, and all into the wound, tissue macrophages. So if they do not come, the fibroblast regeneration, proliferation do not occur, and the presence of a foreign body. So here you can say that non-healing is because of a presence of foreign body. Reepithelialization cannot be done normally because it interferes. The inflammatory phase will go on and on and on. So it will not proliferate, it go into remodeling phase. And presence of hematoma also. If there is a hematoma in the wound, this will attract bacterial growth, and it will go in this will develop wound infection. And then presence of movement and mechanical stress. Suppose the wound is near a joint, this joint continuous movement will break the epithelium that is forming. The reepithelialization is continuously broken, and then this will not promote surface reepithelialization and good fibrin matrix formation. And then presence of dead necrotic tissue also. Lot of bacteria will be attracted to a dead necrotic tissue within the wound. Suppose there is a road traffic accident, because of the abrasion force, and there can be some dead necrotic tissue. Unless the dead necrotic tissue is removed, what we call as debridement, the granulation tissue formation will not start, because This will again attract bacteria, and once the bacterial infection occurs, there is phagocytosis of the cells, the epithelial cells that are being formed. Now, systemic factors that prevent wound healing are, you know, diabetes mellitus, where there is hyperglycemia, which acts as a wound culture for the bacteria in the wound. And also other factors like neuropathic and angiopathy all will add up to the diabetic wound that refuse to heal. Next one is ionizing radiation. Ionizing the wounds that are produced due to exposure to radiation, the epithelialization will not occur in a sequential manner. We have seen that the re-epithelialization in the proliferative phase do not occur here. The cells are dead and they do not epithelialize from the basal layers of the lining membrane. And then temperature, the heat also causes it. Extremes of temperatures like frost or high temperatures will cause necrosis, cell death occurs. So the new re-epithelialization cannot occur. Advanced age, there can be again decreased nutrition, decreased blood supply, protein energy malnutrition can be there, and then the collagen is not adequate enough to be synthesized. Similarly, malnutrition, same anemia, hyperproteinemia, the vitamin deficiencies. Vitamin C is absolutely necessary for collagen synthesis by the fibroblasts. So once vitamin C is not available, collagen synthesis cannot proceed. Similarly, for surface protection, immune protection from the bacteria, vitamin A is necessary in, so for good re-epithelialization. Zinc and iron are also necessary for good re-epithelialization. So if in the absence of these vitamins and minerals, good wound proliferation and remodeling do not occur. So similarly, drugs like steroids and chemotherapy drugs, these prevent any inflammatory phase. We know inflammation is necessary for the wound healing initial phase. They are anti-inflammatory, so there will not be any healing. Similarly, jaundice, uremia, malignancy, all these are factors that hinder the wound re-epithelialization. So now these are some precautions to avoid wound infection in when we are creating an operative wound. You know, surgeons incise and open the cavities, parts, etc. In laparotomy, they open the abdomen. Suppose in thyroidectomy, they open the neck. So how to prevent wound infection? This is some precautions that we should understand. So when we are dealing with post-operative wounds, post-operative patients, we should wash hand in between examination of two patients. We should never carry our bare hands, and we should never carry with the same hands. We should never examine two patients together. Then length of the patient's stay should be kept to a minimum. So just a bit before the surgery and immediately within the prescribed period. If it is a decade surgery, you can immediately discharge, or 2 or 3 days as necessary. As much possible, the the hospital stay should be minimized to prevent nosocomial infections. Then another thing that is being told is preoperative shaving. This will generate small cuts and abrasions, and you all know that there are commensal bacteria, and so there will be already colonization of these wounds by the bacteria, and also the gram-positive bacteria will colonize from the atmosphere these cuts and abrasions that you have caused by shaving. So better do it as close to the surgery time, not the day before night when the surgery is the next day. Immediately within 1 hour you may shave and do the surgery, or you can clip the hair best thing is clipping the hair with the scissors close to the their roots. That this is a better, so that you can prevent microscopic injuries and abrasions and cuts to the skin. Next, and the antiseptic skin preparation should be done properly. You know, when you're painting with the iodine and the Savlon, the migration of bacteria from the adjacent non-painted skin is prevented as much as for 3 hours. So beyond this, the bacteria can migrate into the prepared part from the surgeon's dress and from the adjacent skin of the patient himself. So now, so this antiseptic preparation should be done. Next is, if you're doing a bowel surgery, you do a bowel preparation and then give preoperative antibiotics at the time of induction. You know, there is a period, there is a time called decisive period. We will discuss all this in wound infections in the next chapter. What is decisive period? So this decisive period, roughly it's 4 hours by the time which the body can generate an inflammatory response against the bacteria or foreign proteins that may invade during the procedures. So these 4 hours should be covered by appropriate antibiotic as per the surgery and the invasion of the body cavities. And then the aseptic technique in the theater, that means you know, there should not be too many people around, going around, in and around, out, opening the door several times, because this will produce the air exchanges are much, and unpolluted air from outside will enter the theater and contaminate the theater, which is sterilized by fumigation. So these air exchanges from outside should be kept as much as possible. The people movement should be minimal, and always it should be closed. The door of the theater should be always closed, and hypothermia of the patient should be avoided. And the suture materials also, you should see that monofilament sutures are used more than polyfilament sutures. That means braided. Several sutures intertwined is called polyfilament sutures. So like silk, several. So within this colonized stranded sutures have less amount of infection. So now, proper apposition of the wound and prevention of dead space and hematoma. So dead space should not be there, hematoma should not be there, dead necrotic tissue should not be there. A proper apposition of the wound should be done. Next, what is wound healing? So wound healing are by two methods, that is first intentions or the primary intention, secondary intention, and delayed primary or tertiary intention. Three methods are there. So what is primary intention? So primary intention is when healing occurs with minimal scarring. This is known as primary intention. This is occurs a surgical scar. When it is closed, this will heal with the primary intention. This occurs in clean and uninfected wounds. So with a minimal scarring, healing with minimal scarring is called primary intention. This occurs in a primary surgical wound. This also occurs in clean and uninfected wounds. Any cuts or that can occur by trauma also. If there is no infection, they heal with minimal scarring. Just a line may be there, that's all. But secondary intention occurs when there is extensive loss of tissue or cells. There is a gap in the tissues because of the dead, the tissues are dead. There is a gap in the lining. Now, how is this gap is filled? This is filled by a scar that forms. When Where also there is infection also produces tension in the wound, and the epithelial cells are killed by the bacteria. So the healing with scar formation is called secondary intention. The inflammatory phase is very intense. Large amounts of granulation tissue are formed during proliferative phase, and since the loss of the tissue, the defect is to be filled, this takes a longer time to heal, and more and more granulation tissue, more and more collagen is laid down by the fibroblasts. Myofibroblasts will be there, so wound contraction will occur. Suppose this is wound is near any joint, the joint contraction can occur, right? Suppose in the cubital fossa, if there is wound, there is contracture of the joints can occur if there is the wound is near the joint. Now, healing by, let us go in detail what is healing by primary intention. So healing of a clean uninfected surgical incision approximated by surgical sutures is referred to as primary union or healing by first intention. So during the space, it is first filled with clotted blood containing fibrin blood cells. So within 24 hours, the gap is filled with fibrin. So surface clot forms. So within 24 hours, almost the wound is sealed. So now, next epithelial, after sealing of the wound with fibrin clot, next epithelial cells move from both the edges, depositing basal membrane components. By day 3, macrophages will come. Macrophages secrete fibroblasts. Granulation tissue is found by day 5. By second week, fibroblast proliferation occurs, and then good scar has already found by the end of the month. Cellular connective tissue devoid of inflammatory infiltrate, covered by intact epidermis. So by first month itself, nice healing has occurred with the minimal scarring. So now, what is happening for the bone? How the bone is healing? Primarily, when there is injury to bone, what is happening? So bone also heals by this primary mechanism, that is the periosteal and endoosteal proliferation. The periosteum, the bone, and the endosteum, they start proliferating and they form young immature bone called callus formation. This is by the osteoblasts. Instead of fibroblasts, we have osteoblasts here forming the callus. And then during the remodeling phase, the cortical and medullary differentiation occurs and nice cancellous bone is formed in the gap. So what is happening to the nerve? So nerve when injured, there is Wallerian degeneration. That is, there is degeneration of the nerve as far as the first node of Ranvier. It will go up to the node of Ranvier, and that part of the nerve is degenerated. Now, by mechanism of neurotropism, regeneration occurs and profuse growth of new fibers occur from the nerve end. This is called, the sprouts of new nerve fibers are called neuromas. So these neuromas are very painful, and they remain a cause of concern and pain, and this may not serve any purpose sometimes. Now, what are the tendons doing? Tendons, how they're healing. So we have an intrinsic mechanism and an extrinsic mechanism. So in intrinsic mechanism, that is within the sheath. Within the sheath, there is a vincular blood flow, and with the blood flow, there is synovial diffusion, and the tendon starts healing. There is also an extrinsic mechanism where fibrous adhesions occur between the tendon proper and the tendon sheath. So with this extrinsic mechanism of healing, there can be limitation of movement, adhesion forms. So we have to prevent this adhesion formation by early physiotherapy. So during intrinsic mechanism, rest, next followed by physiotherapy to break any adhesions. Now, let us see the methods of wound management. How should we manage the wounds? So, if the blood supply is adequate, bacterial invasion is not there, you just irrigate and then do proper debridement and irrigation. Then you can primarily suture. But if there is established infection or viability is doubtful, you have to leave it open and then re-explore after 48 hours. If there is infection and doubtful, there is no infection and there is a healthy, you can close it after 48 hours. This is called delayed primary intention. But if there is infection after 48 hours, you have to leave it open and let it heal by secondary intention. So primary intention is by suture closing. Secondary intention is leaving it open for granulation tissue formation. Delayed primary intention is exploration of the wound after 48 hours. Look for any doubtful viability or infection. If it is not there, you close it. You close the wound. So suppose how long, till when you can do a primary closure of the wound. Suppose a patient has come with an injury. So when to close? What is the up to 6 hours? You can do primary closure. You can do irrigation because the chance of infection is less if it is a clean wound. So up to 6 hours you can close it. But beyond 6 hours, you have to leave it open, re-explore and do a delayed primary intention if there is no infection. If there is signs of infection like dead necrotic tissue, heal it with the secondary intention. So primary suturing or primary intention for clean wounds, and then delayed primary suture for contaminated wounds. And then if there is large defects, you can do a secondary intention. Now, I just want to complete with the hypertrophied scar and the keloid scar. So hypertrophied scar is there is excessive formation of collagen in the proliferative phase, and this may continue for some time, up to 3 months, but never beyond 6 months. Then various reasons the hypertrophied scar may occur. This is because of any tension in the wound or against Langer's lines. You know, we have fine lines on the body, or the wound should be placed or should parallel to the Langer's line. If it is across, there can be lot of hypertrophy. Or if there is any infection. Keloid is a familial. The race, it is not related to race. It is only the wound conditions that produce this. This is more common in blacks, and it is the hypertrophied scar is equivalent in male and female, while females have more have keloids than a male. Then children may occur. This is in a 10 to 30 years group. And then another important thing is they remain within the border of the wound. They will never cross the wound. But here it outgrows the wound area. It can grow to normal skin area. This subsides with them. Now, finally, within 6 months, the remodeling, sometimes it's 2 years maybe, but it will subside and it will flatten. But this continue to grow. Then the site is, if it is across joints, then the most common area for keloid scar is on the sternum. Then it can be the shoulders, the face. This is the hypertrophied scar etiology is maybe tension, but here in keloid unknown. This develops within 4 weeks. This can continue 3 months to 2 years after a trauma. See, here you can see this is a hypertrophied scar, how it is limited to the border. But here you can see how this scar has just gone, it has gone beyond the scar, the wound area, and it is extended into the normal area. So this is a keloid that has occurred. So now how to manage the keloid scars, the hypertrophied scar? The first foremost thing is the pressure. Next one is intralesional steroid injection, that is triamcinolone injection. Next, very rarely laser ablations or intralesional excision or post-operative radiation. These are now abandoned, radiation and all, laser treatment or sometimes vitamin E massages, but these are unproven. But excision, intralesional excision, all these have a high rates of recurrence. Okay, so now with this, let us just go and do some bits. So here, the wound healing, this is a PGI bit. So wound healing is affected by age. Yes or no? Is it affected by age?
Yes, ma'am.
Students? Nutrition?
Yes, ma'am.
Drugs?
Yes, ma'am.
Temperature?
Yes, ma'am. Yes, ma'am.
So dryness or wetness is not going to affect, but all others are going to affect. True about wound healing. Infected wound healing, wound healed by primary intention or secondary intention? Students?
Secondary intention, ma'am.
So this is wrong. Deep dermal wound healed by scar formation. Yes or no? Lot of scar. This sometimes you may have to put a graft. They may not heal at all. So this is doubtful. Now wound contraction is found in healing by secondary intention. Yes or no?
Yes, ma'am.
Yes, there is a lot of myofibroblast collagen tissue that occurs. So wound contraction, secondary contraction is common with secondary intention. More intense inflammatory response is seen in primary intention. Yes or no? Students? More intense inflammatory response means more scarring. Is more scarring in secondary intention or primary intention?
Secondary intention.
So this is wrong. So now only true is wound contraction is found in healing by secondary intention. Students, now true about chronic wounds. What are chronic wounds, students? Any wound that does not heal within 3 months.
3
So
months.
this one, monofilament sutures prevent infection. Yes or no?
Yes, ma'am.
Yes. So this is correct. E is correct. May be associated with vascular compromise. Yes or no?
Yes, ma'am.
If there is no blood supply, wound will not heal. Always require surgical treatment. May not be. Right? Found in diabetes mellitus. So only B is the wrong, but others we can put the answers. This is a PGI bit. So multiple answers will be there. Now, cell not involved in the healing of clean wound. So here macrophages, are they necessary? In inflammatory cells, in the inflammatory phase, macrophages are very, very essential because they produce the vasokines. The histamine, bradykinin, kallikrein are secreted by macrophages. So they are not involved. Just see, not involved. So no, this is not answer. Platelet. Are the platelets involved or not?
Yes, ma'am.
They
Involved.
produce prostaglandins. They produce the platelet derived growth factors. They produce transforming growth factors. So platelets are very, very essential. They are to seal the wound. Fibroblasts, are they necessary or not? Are they necessary for wound healing?
Yes, ma'am.
So they are necessary. They are producing the collagen. Then myofibroblasts are also necessary. So what are not much necessary are polymorph or nuclear. Even if these are not in number also, so excessive inflammation is not necessary. So polymorph or nuclear leukocytes are not absolute for wound healing. Next, management of an open wound seen 12 hours after injury. I told you, when can you do primary suturing of a wound? When they come within 6 hours. Here they're saying they have come after 12 hours. So what should you do? Suturing, will you suture the wound or you just do irrigation and immediately you do suture? Or you do delayed primary suturing, debridement and suture, secondary suturing, heal by granulation. What will you do when you see a wound after 12 hours after injury? Suppose you are in the casualty, they have brought a boy with an injury. It is more than 6 hours. So what do you have to do? What do you have to tell? You have to clean, irrigate, wash, bandage. Tell them to come after 2 days. Check the wound. Then you do delayed primary closure. Understood, students? So here, maybe what fits is debridement and second delayed primary suturing. Probably B should be the answer. Next, vitamin which has inhibitory effect on wound healing. Vitamin A, is it favorable, necessary or not? A, students, are you
Necessary.
there?
Yes, ma'am.
A is necessary, C is necessary, B is necessary. What is not inhibitory effect is vitamin A. It has an anti-inflammatory effect in large doses. It has an anti-inflammatory effect and it may prevent wound healing. That is why they apply the wound vitamin E oils on the hypertrophied scars. They think that this will inhibit collagen formation, right? So vitamin E has an inhibitory effect. So tensile strength of the wound starts when it will start immediately 3 to 4 days, 7 to 10 days, 6 months. So the actually this it can be immediate, early tensile strength, late. Early tensile strength will start as early as 3 to 4 days, while the late tensile strength will come during the remodeling phase. So 3 to 4 days can be the answer here, right? In a sutured surgical wound, the process of epithelialization is completed. I have told you, primary intention, you're closed. When will the process of epithelialization will be completed? It is bridged within it is 24 hours, but the epithelialization is completed within 72 hours. Okay, so the process has started and is completed. So 72 hours. Factors that adversely affect the healing of wounds include exposure to UV light, exposure to radiation, obstructive jaundice, advanced neoplasia. So all except. So radiation will not favor healing. Similarly, jaundice will not, and then malignancy will not. So what is left is only exposure to UV light. We are all exposed to UV light. UV light is the sunlight. So should be answer A. So primary closure of incised wounds should be done within
6 hours.
2, 4, 6, 12, 16.
6
So it
hours.
should be done within 6 hours. Very good. Next, this one is a tricky one. Following are required for wound healing: zinc, copper, vitamin C, calcium. I think zinc, copper, vitamin C are needed for the epithelialization, collagen deposition, while calcium is not so essential. Next, the patient has lacerated untidy wound of leg and attended the casualty after 2 hours. His wound should be. So untidy wounds, what should be the method? It is sutured
Debridement.
immediately.
Debridement.
Debrided and sutured secondarily. That means you ask them to come after 48 hours and then you check and do. If there is infection, don't suture. So cleaned and dressed. This can also be the answer. So cleaned and dressed. Untidy wound of the leg, attended the casualty after 2 hours. His wound should be cleaned and dressed. I think this is the one best answer suiting. Do you agree with me, students? Students?
Yes, ma'am.
When is the maximum collagen content of wound tissue? See, collagen content is maximum in the proliferative phase, isn't it? So 17th to 21st day. You can keep that the later part of the proliferative phase you can keep, right? Next, delayed wound healing is seen in malignancy. Yes. Diabetes. Yes. Infection. Yes. So except, this is except with hypertension. This must be the answer. In the healing of clean wound, the maximum immediate strength of the wound is reached by 13 to 18 days. You can keep this, right? Normally, you don't get this much. It will take minimum 3 months, 3 to 6 months. A clean incised wound heals by primary intention, right? Fibroblasts in healing wound are derived from where? Mesenchyme, epithelium, endothelium, vascular fibrosis. So where from are the fibroblasts are derived? So fibroblasts are derived from the basal membranes. So this must be the answer. Which one of the following surgical procedure is considered to have a clean contaminated wound? Actually, this we have not discussed, but this bit has come. The wounds classified as clean wounds, clean contaminated wounds. We will talk next class. So now bits on keloid and hypertrophied scars. True statements regarding hypertrophied scar. So this is the PGI bit. It is given as statement as so one or more answers. Grow beyond wound margin. Will they grow beyond wound margin? Hypertrophic scar, will it grow beyond margin?
No, ma'am.
Common in females, need not. Only keloids are more in female. Not familial. Yes or no? Is it true?
Yes, ma'am. It's not for me.
It is not familial. It is not race related, and it subsides within 6 months. So C and E should be the answers. Now all are true about keloid except grows beyond. This is except bit. Be careful. So grows beyond wound margin. Yes or no?
Yes, ma'am.
Yes. Excess collagen deposition. Yes or no?
Yes, ma'am.
Yes. Precancerous. Is it leading to cancer? No. It is not true. More common in female. Yes or no?
Yes, ma'am.
So it is common. This is true. So except whites are more common than blacks.
Black.
This is wrong now. Blacks,
Yes,
negroid
black.
race are having. So this must be the answer. And I feel precancerous leading to cancer is also wrong. Keloids are not cancerous. Next. Most common site of hypertrophied keloid. Well, most common site for a keloid scar. Can you tell? I have showed you. Sternum. Sternum is the most common cause area, right? Next, first line of treatment for keloid is intralesional injection of local steroid. Not, this is wrong maybe. Local steroid injection, triamcinolone injection, intralesional injection is the initial treatment for keloid. Drugs used for intralesional injection is triamcinolone. So keloid scar is made up of dense collagen, loose fibrous tissue, granulomatous tissue, loose areolar tissue. So dense collagen is the answer. The following statement about keloid is true. They do not extend into normal skin. Is it true or false, students?
False, ma'am.
So it is false. Local recurrence is common after excision. True or false? Yes. Even if you excise also and do grafting, they will recur at the edges. Again, they will recur. So this is common. Next, they often undergo malignant change. This is also not true. So this is true. They are more common in whites, not true. So C, D, A are not true. Local recurrence is common after excision is the true answer. In an open injury, during toileting and debridement, muscle viability is detected by what? Suppose a patient has come with a road traffic accident, lot of tissue crushing is there, crush injury is there. So you are doing debridement. Debridement is removing of dead necrotic tissue is called and it's called debridement. So when you are doing the debridement, how do you know that the muscle is viable? Color of the muscle, size of the muscle, function of the muscle, muscle contractility, punctured bleeding spots on cut edge. Which one do you? This is the PGI bit. So several answers can be there. Color of the muscle. Yes, dead muscle will be black in color, while pink colored muscle indicates that the muscle is viable. Muscle size, nothing to do. Muscle function, nothing to do. Muscle contractility, yes. You ask the patient to move, the muscle will contract, yes. When bleeding on cut edge, if you cut, bleeding spots can be there. So I feel color of the muscle, contractility, and bleeding on cutting, these three are indication that this E may not be. A and D are answers for the PGI bit. Next, best scars are seen in infants, children, adults, very old people. So best scar, if in these four, infants are the best scars. If suture marks are to be avoided, skin sutures should be removed by 72 hours, 1 week, 2 weeks, 3 weeks. So if you don't, suppose you are doing ear lobule suturing, something like that, where you don't want any marks, suture marks, they should be early. When you know the epithelialization occurs within 48 hours, we have read no in a primary intention. So by that time you can remove. By 72 hours you can remove if you don't want skin sutures to be having marks on the skin. What is degloving injury? So degloving injury means the skin will come off like a glove. As you remove a glove from the hand, the skin will be just removed, the avulsed. This is the type of avulsion injury. So this we have not. The type of injuries, wounds, and all we have just covered wound healing. Maybe in next class we'll do that. Okay, students. So with this, today we have covered the phases of wound healing, the inflammatory phase, the proliferative phase, and the remodeling phase. Factors favoring the wound healing, factors not favoring wound healing, and we have also discussed the management of the wounds, the primary intention, secondary intention, and delayed primary intention or a tertiary intention. And then we have also discussed about the keloid scars and the hypertrophied scars. What shall we have for the next class, students? Do you have any suggestion? Shall we continue with wound and wound infections, or shall we go to any specific? Have any doubts, students? Do you have any doubts, students?
No, ma'am. Continue with this topic,
Huh?
ma'am.
You have understood?
No doubt, ma'am.
What shall we have for next class?
Yes, ma'am.
What shall we have?
Continue, ma'am, this topic.
Continue with the wounds, type of wounds, lacerated wounds, then classification of wounds, right? And then if possible, I will traumatic wounds, trauma also I will cover. Thank you, students. All the best.